So in this slide, what we're looking at is a comparison of the ovarian cycle to the uterine cycle, as well as changes in hormonal levels you find influencing these cycles. So earlier we talked about how the hypothalamus released gonadotropin-releasing hormone, and that stimulated the anterior pituitary to release FSH and LH, or follicle-stimulating hormone and luteinizing hormone. And we said that the follicle-stimulating hormone stimulated the growth of primordial follicles into a primary follicle, and that the follicular cells of that primary follicle were able to start to release estrogen. That's what we see here, guys. So if you look here in the primary follicle, that's out now developing the ovary around the first several days. What we find then is that from this primary follicle that's starting to develop and grow, estrogen levels are rising because it's the follicle itself that's releasing estrogen. Remember, estrogen stimulated follicle growth. So once estrogen starts to be released by the primary follicle, that estrogen stimulates the follicle to grow even larger. So the primary follicle develops into a secondary follicle, which releases more estrogen, which then develops into a mature follicle or tertiary follicle, which releases even more estrogen. So we said that at low concentrations, estrogen had an inhibitory effect on the hypothalamus and pituitary. And the evidence of this is if we look over here, guys, we said that as estrogen levels rise, FSH and LH levels either start to fall or they remain unchanged, which suggests some inhibition here. So estrogen at low concentration inhibits FSH and LH. And the idea behind this is that you wouldn't want too many primordial follicles developing simultaneously. So that by inhibiting, once you get a little bit of estrogen being released by a growing follicle, then that you can inhibit further follicles from developing by inhibiting the release of FSH and LH by the anterior pituitary. So then as these follicles started to grow larger, we talked about how the estrogen levels were also increasing from the larger follicle. And so that once these follicles become very large, just prior to ovulation, we have our mature follicle or tertiary follicle here, estrogen levels are at their peak. And we said that at high concentrations of estrogen, that actually is no longer inhibitory on the hypothalamus and pituitary. It actually now becomes stimulatory. So at high concentrations, estrogen actually stimulates the hypothalamus to release GnRH, which stimulates the anterior pituitary to release LH. So in response to a big old surge in estrogen, what we end up with then is something called an LH surge. So the LH surge here, luteinizing hormone surge, it's a rapid increase in luteinizing hormone in response to high estrogen levels. And we said that estrogen levels were high because the follicle was more well developed and it's releasing a lot of estrogen. Now it makes sense from the standpoint of if the follicle is so highly developed and large that it's ready to be ovulated, right? So that estrogen levels at their peak stimulate the release of luteinizing hormone, and that is the stimulus for ovulation to occur. So right at mid-cycle, day 14, this LH surge is the stimulus for ovulation where the oocyte, which is secondary oocyte, gets expelled out of the tertiary follicle into the pelvic cavity. So what we see here then is this secondary oocyte is actually erupting from the surface of the ovary. That's what this picture is showing. However, there were some cells that get left behind in the ovary right here. This sort of C structure of cells are the follicular cells of the ovarian follicle, right? Although this is the oocyte that gets ovulated, there are some cells that get left behind in the ovary. Those cells that get left behind, the follicular cells, after ovulation, these follicular cells actually develop into something called corpus luteum. Corpus luteum means yellow body, and we said that corpus luteum is basically a huge factory of progesterone and estrogen. That's why we see that right after ovulation here, we can see then that due to the corpus luteum that's now developing, we see a rapid rise in progesterone levels. So that progesterone levels now spike after the estrogen levels did. And you see that estrogen levels fall because as corpus luteum develops from the follicle, now you get more progesterone being released than estrogen. Okay, so then progesterone levels rise. And it's this increase in progesterone that actually stimulates growth of the endometrium even more so. So that right after ovulation, the uterus, the endometrium of the uterus, enters what we call the secretory phase here, and it's due to this rapid increase in progesterone, where progesterone has a stimulatory effect on the growth of the connective tissue of your endometrium. So what happens is that the connective tissue gets thicker, you get more blood vessels that grow into that tissue, you get hypertrophy of the endometrial glands, which are mucus glands that actually secrete protective and nourishing mucus here in the lumen of the uterus. And it makes sense from the standpoint of if the endometrium is what harbors the potentially fertilized egg, how progesterone increases in concentration after ovulation to cause the endometrium to grow thicker and potentially harbor that ovulated egg if it gets fertilized. Now, if fertilization doesn't occur, what happens then is corpus luteum then degrades. And as it degrades, it stops releasing as much progesterone, and so progesterone levels start to fall. And as progesterone levels fall, estrogen levels also fall with that because you get a little bit of estrogen being also released from corpus luteum. So that as progesterone and estrogen levels fall, once those hormone concentrations get low enough, now what that stimulates is actually the beginning of the menstrual phase. So day 1 here, you can see, here's day 1, is that this begins the menstrual phase, which is basically a shedding of the stratum functionalis of your endometrium. So that due to low progesterone and estrogen levels, bless you, this is what stimulates a shedding of the endometrium, and it begins the menstrual phase. Now, because progesterone and estrogen had an inhibitory effect on the hypothalamus at high concentration, what happens is once progesterone and estrogen levels get low enough, you're actually removing that inhibition. So what we see here then it correlates with the decrease in progesterone and estrogen is actually an increase in FSH and LH, which you can see here. And so this increase in FSH and LH stimulates primordial follicles to develop into a primary follicle, and the whole process repeats. Okay, so what is the stimulus for the development of primordial follicles into primary follicles?
The release of
low levels of progesterone and estrogen, which removes the inhibition from the hypothalamus and pituitary, right? So what hormones released from the hypothalamus and pituitary would stimulate the development of primordial follicles? Yeah, specifically FSH, because it's the follicle-stimulating hormone, right? So by removing that inhibition, then your hypothalamus releases more GnRH. That stimulates the anterior pituitary to release more FSH and LH, but specifically FSH is what can help bring primordial follicles out of that state and bring them into the primary follicle stage, which is what we see here. And then what is a stimulus for these follicles to grow even larger beyond FSH? Estrogen. Yeah. The estrogen that's being produced by the follicle itself, right? And so that we see that once the follicle starts to develop, we get the primary follicle, we see that estrogen levels start to rise, right? So estrogen levels are rising because the follicles are getting larger and larger, and it's estrogen that's actually stimulating the follicles to get larger. So it's a positive feedback mechanism, right? Now, at low concentrations, what's the effect of estrogen on the hypothalamus and pituitary? It inhibits it. Good. So it inhibits the GnRH, FSH, and LH. And what's the significance of estrogen being released by the follicle inhibiting any more FSH and LH from being released?
You don't want more follicles.
You don't want more follicles.
Yeah, you got it. You don't want more follicles developing. So it kind of closes the door behind it. Once some of the follicles get through, they close the door behind it and they say, nope, no more. Because it actually inhibits FSH and LH from being released by the pituitary. So when estrogen levels get high enough, because the follicle is now large and it's releasing a tremendous amount of estrogen, what's the effect of estrogen on the hypothalamus and pituitary at high concentration? It excites it. It stimulates it. You got it. So it stimulates the hypothalamus to release GnRH, which then stimulates a big old surge in luteinizing hormone. And this LH surge is the stimulus for ovulation. Now, one thing we didn't mention yet is down here, you guys, after the menstrual phase, we see then is that the endometrium starts to regrow. But the initial phases of regrowth of the endometrium during the proliferating phase are due to this increase in estrogen. So that as the follicles are starting to develop, that itself stimulates the endometrium to regrow, right? The stratum functionalis is stimulated to grow by these rising estrogen levels. But what causes the stratum functionalis of your endometrium to grow even thicker after ovulation? Yeah, progesterone. You got it. So you see the progesterone levels spike here, and it causes the endometrium to grow even thicker. So the connective tissue is getting thicker. You get more blood vessels, more mucus glands. So it's more hospitable to a potentially fertilized egg. And then where does the progesterone come from that stimulates the regrowth of this endometrium?
Corpus luteum.
Yeah, so up here, corpus luteum. And then where does corpus luteum come from? Yeah, the follicular cells, right? Yeah, after ovulation, these follicular cells turn into corpus luteum. Exactly. It's a big old factory of progesterone. So then progesterone levels rapidly rise. And yes, it does cause the endometrium to grow thicker here. However, progesterone also causes thickening of the cervical mucus, so that if copulation hasn't occurred yet and there aren't sperm there, effectively what this progesterone does is it causes cervical mucus to thicken, which if there are sperm in the uterus at this point, then they can't escape or leave because now they're trapped behind this mucus plug, right? If copulation hasn't occurred yet, then the sperm will have difficulty or be unable to enter the uterus because the cervical mucus is too thick at this point. So what this means is there's a very narrow window for fertilization to occur. And it's just, in a short period of time right after ovulation, because after ovulation, you start to see a rapid rise in progesterone levels, which, yes, it does cause your endometrium to grow thicker, but it plugs the cervical mucus. So what we find here then, you guys, is that progesterone does have an effect on the brain too, not just the uterus, but what's the effect of progesterone on the hypothalamus and pituitary at this point? It's inhibitory. You got it. Check that out, you guys. You can see that FSH and LH are also remaining at fairly steady concentrations. And in fact, if you look closely, they're even kind of degrading or slowly going lower concentration. So why would you want progesterone to inhibit the release of FSH and LH?
You don't want two different follicles.
Yeah, exactly. Because during this period of time, you just ovulated an oocyte. You don't need more follicles to start developing, right? What you rather would, set up a situation would be to basically make the uterus more hospitable and give that that ovulated oocyte, the chance to get fertilized and properly implant before other ovulation occurs. And so this will continue for a week or so. But if fertilization doesn't occur, what happens to corpus luteum? It degrades into corpus albicans. And if you had to describe corpus albicans as something, what's it like? Scar tissue, right? And does it release a lot of hormone? No. And so as it decays, then progesterone levels and estrogen levels also fall. And so once progesterone and estrogen levels get low, what's the effect of that on the brain?
Well, does it stimulate or it just doesn't inhibit?
Well, you remove the inhibition, which in another way is kind of like saying it's stimulatory. But by removing that inhibition, now you're increasing the release of FSH and LH, right? Which means you're starting the whole process over again, because as FSH and LH levels start to rise when progesterone levels are low, because the inhibition's not gone, that this can now stimulate more primordial follicles to develop, right? But what's the effect of falling progesterone levels on the uterus?
Sloughing of the lining.
Yep, sloughing of the endometrium. Now, is it stratum functionalis or stratum basalis? Stratum functionalis, you got it. And what happens to all that sloughed material? Yeah, it comes out, right? That's the menstrual flow, right? So, what do you guys think is the significance of that? Why even have a menstrual flow? What's the point of this? Well, yeah, to shed it, but why even shed it? Why not just grow it once and just leave it?
So it doesn't
It
accumulate
doesn't
bacteria.
stay in there.
Say it again?
You don't want to implant an egg.
Why not?
Like, just leave eggs there because it would continue to grow.
Good point.
And
Cells could accumulate, and cells have a lifespan. If you never shed the stratum functionalis, then you'd have a lot of eggs just hanging out there, right? Which means that they could potentially be fertilized if they were still alive. Which means, if you didn't,
then you could have a litter too.
you could have a litter that way, exactly. But it could be a litter because you never, basically expelled those oocytes, and so that they were accumulating there. In reality, what it relates to, though, is actually more or less keeping this tissue fresh. And by having a new connective tissue with new blood vessels and new epithelium, it's more hospitable because you're less likely to find scar tissue or any other kind of sources of injury. And so it's more hospitable by having a fresher tissue. So, this stuff regrows and sheds within every 28-day cycle. And this continues throughout the reproductive years. And so what you want to be able to do then is identify the phases and be able to tell me what's happening in each phase, right? So if I said, what is the stimulus for ovulation, you would say
FSH.
LH surge, right? And what's the stimulus for the LH surge?
Decrease in.
Oh no.
No,
Estrogen, right? And where did the estrogen come from?
From the release
From
of
the follicle.
From the follicle, right? And why did the follicle get big? Because the estrogen, exactly. And then what even allowed the follicle to develop to begin with?
No,
FSH.
non-inhibition of FSH.
So it's true that estrogen causes the follicle to grow, but I guess maybe a better way to rephrase that question would be, what allowed the primordial follicle to develop into a primary follicle to begin with? FSH and LH. You got it. Good. So what's the effect of estrogen on the uterine lining if it's in high concentration? Yeah, it causes it to grow, right? What's the effect of progesterone on the uterine lining in high concentration? Also causes it to grow, even thicker, right? What's the effect of low progesterone and estrogen on the uterine lining? Sloughing, menses, exactly. You got it. So you might wonder, where does it go? Well, it sloughs and it leaves the cervix into the vagina, right? So the vagina literally translates to sheath. And so the vagina is a fibromuscular tube that's about 10 centimeters in length, connects the uterus and the outside of the body. It's a thin, distensible wall, has three tunics. You got a mucosa, which is the non-keratinized stratified squamous epithelium. You got a muscularis there as well, which is also smooth muscle, and an outer layer of adventitia, which is effectively just like a dense fibrous tissue. Now, our mucosa is this non-keratinized stratified squamous epithelium. It also has a highly vascular lamina propria to nourish the epithelium. But as a non-keratinized stratified squamous epithelium, it's tough, but it's non-keratinized, so it's not waterproof, which means it's a mucous membrane. Now, the opening of the vagina, bless you, is the vaginal orifice, and in children or prior to sexual encounters, the vaginal orifice can sometimes be covered with a hymen, which can be either complete or incomplete. And it's essentially just a thin layer of tissue that covers that vaginal orifice. Now, the histology of the vagina, what we find, you guys, is that it's a stratified squamous epithelium, non-keratinized, and it's thick, which basically means that it's tough, right? It's highly resistant to abrasion. Deep to that, we have a lamina propria, which is essentially loose areolar connective tissue that helps nourish this epithelium. Because our epithelial tissue is vascular or avascular? Avascular, right? Epithelium don't have blood vessels, so what this means is all these cells that line the inside of the vagina need to have nourishment from an underlying vascularized connective tissue, which is here. Now deeper, we have a muscularis, which we have some smooth muscle, and then even outside of that, which isn't shown here, is an adventitia, which is just like a dense fibrous tissue. Now, some external structures we could see, you guys, is effectively our mons pubis, which is that adipose pad just anterior to the pubic symphysis. We have our labia majora out here, just thin skin with hair. We have our labia minora, which is actually a little bit more medial, and it's going to be a stratified squamous epithelium. It is keratinized, and it does have melanocytes as well. And the labia minora, as thick skin, doesn't have hair, but where the minora meet here, they form a clitoral hood, also called the prepuce, just like there's a prepuce in the penis. Remember, that's the foreskin of the penis. There's also a prepuce in the clitoral hood. Again, the clitoris and penis are very similar developmentally. In fact, the clitoris is right here, just covered by the prepuce or clitoral hood, and that is essentially the clitoris is essentially going to be erectile tissue that's highly sensitive. There's a lot of nerve endings there. In fact, it has some of the most dense concentration of nerve endings in the body. But the clitoris is erectile tissue, so it will engorge with blood during sexual excitement. That's what we can see here, you guys. Just got some erectile tissue here. What we find then is that associated with the labia minora here, we have what's called the bulb of the vestibule. Bulb of the vestibule is some more erectile tissue, which is nearby, and actually that's why the labia minora can engorge with blood during sexual excitement as well. And then near the vaginal orifice here, the opening of the vagina, what we find then is some glands nearby, the greater vestibular glands. The greater vestibular glands are analogous to the Cowper's glands in males, and they basically produce a clear, viscous type of lubricant that's created during sexual excitement. And it makes sense you'd find that right near the vaginal orifice here. Now, the mons pubis was that expansive skin and subcutaneous tissue just by the pubic symphysis. Labia majora were paired, thickened folds of skin that have hair, and they have sebaceous and sweat glands. In fact, remember there was a type of sudoriferous or sweat gland we only found in the groin and axillary and periareolar area. Remember the apicrine sweat glands? Those apicrine sweat glands produce the kind of oily type of sweat that's associated with body odor. Well, you find those near the labia majora, just like you find them near the scrotum in males. In fact, labia majora is analogous to the male scrotum. It's effectively the same kind of tissue, thin skin with hair. And these types of glands are associated with, body odor, but they also think it's associated with pheromonal communication, which is interesting. Now, the labia minora are paired folds just medial to the majora. They're devoid of hair because it's thick skin, and it's vascularized with lots of melanocytes. Now, because it's so dense in melanocytes, it is common for melanoma, or basically that form of skin cancer, to occur in the pelvic area because there are a lot of melanocytes in that particular area. Now, the space between the labia minora is called the vestibule, and the vestibule is just what opens up into the vaginal orifice. And we also have our urethral opening just superior to the vaginal orifice. Now, the greater vestibular glands, or glands of Bartholin, they're effectively glands that produce a mucus type of lubricant during sexual excitement. And the clitoris, like we talked about, you guys, is superior to the urethral opening, and it's analogous to the corpus cavernosum of males, which is basically erectile tissue. And we do have a cap in the body of the clitoris, which is the glands. So like the penis, there's a glands of the clitoris. And there's a prepuce around the clitoris too, which is this external fold of the labia minora that forms a hood-like covering. And just like there's a prepuce on the penis, there's a covering of the clitoris as well. So they are analogous or similar. Now, in terms of structure of the breast, we talk about them as having mammary glands. But the entire breast is not all mammary gland. In fact, most of what breast tissue is actually adipose. We have mammary glands within a breast, and those are just effectively modified sweat glands that produce milk. And milk's a complex mixture of protein, fat, and sugar that serves as nutrition for infants. The nipple is a cylindrical projection in the center of the breast that contains multiple openings for secretory ducts from these mammary glands. And the areola is that pinkish-brown pigmented ring that surrounds the nipple. Now, around the areola, we do find hairy skin. In fact, we also find apicrine glands around the areola here. And so apicrine glands, we talked about, were the ones that were associated with body odor. And they're also associated with pheromonal communication. So there is some pheromonal communication around the areola here. The center of the areola, we have the nipple. And the nipple actually is the exit point for some of these lactiferous ducts. You see our lactiferous ducts exit at the nipple. And if you follow those lactiferous ducts back, what we find is it leads into breast tissue. And the mammary gland itself is actually kind of a harder type of tissue you find in the breast. And each of these are have lobes, and the lobe is just these large things here. These lobes have lots of lobules, and the lobules have alveoli, which, if you remember, it sounds a lot like the structure of a lung, right? So the structure similarly, however, this isn't air-filled. It's filled with mucus and breast milk. Now, once active in response to hormones like prolactin, these lobules and alveoli within that have a cuboidal type epithelium that makes breast milk, and it all leads back up to the nipple. But then we also have hormones for lactation as well. Remember, oxytocin was what stimulated milk letdown, as well as uterine contractions. But you need an adequate amount of oxytocin for breast milk to be secreted from the nipple. But again, you guys remember, breast milk is made from like modified sweat secretion. So it's mostly water, some protein, sugar, and fat. But it's involved with nourishment. And there's some evidence to suggest that for women who do breastfeed rather than rely on formula, breastfeeding is actually protective against breast cancer. And if you don't breastfeed, that actually puts you at a higher risk for breast cancer. And the evidence for this is you find in some women who only breastfeed with one breast, they're more likely to have breast cancer in the breast that they didn't feed with. You know, like if you have your infant in a sling and it's just kind of feeding on one breast, and you only ever wear the sling on one side, not the other, you're more likely to get breast cancer in the opposing breast that you didn't use to breastfeed with. We'll talk more about breast cancer when we get to pathophysiology. Now, our mammary gland here is divided into lobes, which are divided into lobules. Within that, we have our alveoli. Those lead into lactiferous ducts, which lead into a lactiferous sinus. And those basically lead into the nipple, which is how milk is drained. Now, the whole breast itself is supported by suspensory ligaments. If we go back here in this picture, we see that most of the breast structure is actually adipose. Remember, adipose is one of the loose tissues. It's a loose connective tissue. So it doesn't have much structure to it. And so if you think about the structure of the breasts, it's mostly adipose, which means it's loose. Well, how does it have any kind of shape and position to it? Well, the entire breast itself is actually supported by a lot of these suspensory ligaments, which is essentially like a superficial fascia that you find within the subcutaneous tissue here. And it helps anchor the mammary glands to the underlying muscle. So if you guys look here, we have our pectoralis muscle just deep to the breast, and there's suspensory ligaments that hold this in place. There's also evidence to suggest that women who wear bras over the course of their lifetime, their suspensory ligaments go away, right? Think about, like, if you're wearing a bra and it's holding your breast in position instead of suspensory ligaments doing that for you, then you start to lose that tissue. So then what happens over time is that there's some evidence to suggest that women who wear bras, there's less structure to their breast later in life due to loss of those suspensory ligaments, right? Yeah.
So are you saying that we should wear Burn them like our
We
ancestors.
wouldn't have to wear bras.
If you-
we
if-
didn't wear bras from the beginning.
If women didn't wear bras, you're more likely to maintain your suspensory ligaments, which basically means that your breasts would be less likely to, sag later in life. There's not. I mean, there was one research study on that more recently. Surprisingly, it was a French study, right? Or unsurprisingly, right? Of course, right? Yeah, exactly. Sounds very French, right? But I mean, it's still interesting. It makes sense from the standpoint of use it or lose it, right? Now, so that's what these suspensory ligaments are saying here, you guys. Basically attach the glands of the breast to the underlying pectoralis muscle. Now, one of the reasons why breast cancer is so vigorous and fatal is that if you look at the structure of the breast back on this slide too, you guys, is that most of the breast tissue is adipose. Adipose is loose. So if the cancer arises from the glandular epithelium of the breast mammary gland here, it can spread more easily.